Bismillahirrahmanirrahim. Thought of the day is optimism is the faith that leads to achievement. Nothing can be done without hope and confidence. Assalamu alaikum. My name is Dr. Inshrah and I'm a PG of Clinical Medicine and Public Health at King Edward Medical University, Lahore. Today, the topic of my presentation is cholera, and I'll be presenting it under kind supervision of Professor Dr. Saira. Our learning outline will be introduction to cholera, its history, disease transmission, clinical features, diagnosis, treatments, prevention, global data, recent updates, and then MC. At the end of this presentation, the participants will be able to understand cholera and its impact, identify disease transmission and clinical features, diagnose cholera effectively, explore its treatment, prevention strategies, and analyze global cholera trends and control efforts. Clinical scenario. A 28-year-old military man stationed in a flood-affected area presented to the emergency department with complaints of profuse watery diarrhea for the past 24 hours, accompanied by muscle cramps, severe weakness, and the signs of dehydration. The diarrhea, described as rice water stool, occurred more than 10 times daily. He reported drinking untreated river water 2 days earlier, as no clean drinking water was available. He was taken to the medical camp where a doctor did his examination. On examination, he appeared fatigued and lethargic, with sunken eyes, dry mucous membranes, and prolonged skin tensing. His vital signs revealed hypotension, tachycardia, and signs of hypovolemic shock, cold, clammy extremity. Laboratory tests were done, including CBC, ESR, and stool tests. Stool analysis showed water stool with no blood and leukocytes, indicative of excretory diarrhea. A stool culture identified Vibrio cholera OI, which was confirmed through serological testing. A rapid diagnostic test for Vibrio cholera O1 antigen turned positive and diagnosis of cholera was confirmed. Introduction to cholera. Cholera is an acute diarrheal illness caused by Vibrio cholera, marked by sudden profuse watery diarrhea followed by vomiting, leading to dehydration and electrolyte imbalance. Its transmission is through contaminated water and food particles, particularly in areas with poor sanitation. Unless there is rapid replacement of fluids and electrolytes, fatality may be as high as 30 to 40%. It is endemic in developing countries, causing high morbidity and mortality, especially during outbreaks where vulnerable populations such as the children and the elderly are most affected. Controlling cholera requires robust public health measures, including access to clean water. History of cholera. Cholera originated in India and was first identified as a major disease during the first pandemic in 1870. The disease spread rapidly through global trade routes, leading to 6 major pandemics by 1922, severely affecting populations in Asia, Europe, and Africa. The last pandemic began in 1961, caused by the Vibrio cholera E1 star strain, which has since become the dominant cause for cholera worldwide. In Pakistan, cholera outbreaks have been notably linked to floods and inadequate sanitation systems, which creates conditions for the contamination of water sources, leading to widespread transmission of the disease. This is a picture that shows different cholera pandemics. The Public Health Act of 1875 in England was pivotal response to cholera outbreaks and poor sanitation conditions. Key provisions related to cholera include sanitation improvements, disease prevention, public health infrastructure. This act significantly reduced cholera incidence by addressing its root cause, such as contaminated water and poor hygiene, and laid the foundation for modern public health systems. Dynamics of disease transmission includes obviously the agent factors, host factors, and environmental factors. Now we will discuss all of these one by one. Agent factors. The causative agent of cholera is Vibrio cholera, a gram-negative bacteria. It has two serotypes, Vibrio cholera O1, which includes two biotypes, classical and T1 TOR, and Vibrio cholera O139. Its pathogenicity is largely due to the production of cholera toxin, which disrupts normal electrolytes and fluid balance in the intestine, leading to severe diarrhea. The bacteria are highly infectious with a low infectious dose required to cause disease, especially in areas with poor sanitation. Vibrio cholera is killed within 30 minutes by heating at 56 degrees Celsius or within a few seconds by boiling. It remains in ice for 4 to 6 weeks or longer. Drying or sunshine will kill it in a few hours. It is easily destroyed by coal tar disinfectants such as cresol. Bleaching powder is another good disinfectant. Host factors. Many host factors contribute to the spread of cholera. Among these include age. Young children and the elderly are most susceptible to severe disease. Immunity. The host immune status plays a significant role in cholera transmission. Individuals who have previously been exposed to the disease may have partial immunity, though it is not lifelong. Nutritional status. Malnutrition and underlying conditions such as HIV or chronic illnesses can also increase the risk of severe cholera. Pregnancy. The physiological changes during pregnancy, such as increased blood volume and altered immune function, can make them more susceptible to the severe effects of the disease. Environmental factors. Cholera is transmitted heavily influenced by the environmental conditions, such as water supply. Contaminated water sources, often due to floods, poor sanitation, and inadequate waste management, are the primary medium through which the bacteria spread. Climate change. Increased frequency of extreme weather events like floods can exacerbate these conditions, leading to outbreaks. Hygiene practices. Poor hygiene practices, especially in crowded settings, also contribute to the spread of the disease. Chain of transmission includes reservoir, carrier, source, mode of transmission, and reservoirs. Infected humans and aquatic environments like rivers and lakes, especially in warm climates. Carriers include asymptomatic individuals who shed Vibrio cholera in their stool and contaminate water or food. Source, contaminated water and food, often due to poor sanitation or floods. Mode of transmission includes fecal-oral routes through contaminated food or water. Hosts are the individuals with poor hygiene or weakened immunity, such as children and the elderly. Pathogenesis. Step 1. Ingestion of Vibrio cholera. The infection begins when a person consumes food or water contaminated with Vibrio cholera. A small number of bacteria are sufficient to cause illness, especially in areas with poor sanitation. Step 2. Colonization of the small intestine. Once ingested, Vibrio cholera travels to the small intestine, where it adheres to the intestine walls using villi, which are hair-like structures, allowing the bacteria to establish an infection. Step 3. Cholera toxin production. The bacteria produces cholera toxin, which binds to the intestine cells and stimulates the excessive secretion of electrolytes and water into the intestine. This results in the characteristic watery diarrhea, often called rice water stool. Outcome. The excess fluid loss leads to severe dehydration, electrolyte imbalance, acidosis, and if left untreated can cause shock and potentially be fatal. Rapid rehydration is crucial to recovery. This is a picture showing pathogenesis of cholera. First of all, there is ingestion, then shedding into the small intestine, adhesions with the use of villi, toxin production, and then detachment. Incubation period. The incubation period for cholera ranges from 1 to 5 days, depending upon the amount of Vibrio cholera ingested and the individual's immune response. A high dose of bacteria can shorten the incubation period, while a strong immune system might delay the onset of symptoms. Period of infectivity. Individuals infected with cholera are most contagious during the diarrheal phase, as Vibrio cholera is actively shed in the stool. The infectivity can persist for several days even after recovery, as bacteria continue to be present in the stool for up to a week, potentially contaminating the environment and spreading the disease. Clinical features. An individual with cholera may present in two forms, mild cases or severe cases. Mild case. Asymptomatic or mild diarrhea that may go unnoticed and does not typically require medical intervention. Severe cases. Profuse rice water stool, large volumes of watery diarrhea with a pale, cloudy appearance, often described as odorless. Severe dehydration. Symptoms include intense thirst, dry mouth, skin, sunken eyes, and lethargy. Vomiting. often occurs alongside diarrhea, leading to rapid fluid loss. Muscle cramps due to significant loss of electrolytes like potassium and sodium, oliguria or anuria, reduced or absent urine output due to dehydration, hypotension and shock, low blood pressure leading to rapid pulse, cold extremities, and eventually collapse if untreated. Altered mental status, confusion, drowsiness, or irritability in advanced dehydration stage. These are the different symptoms of cholera. Stages of cholera. Overview. There are three stages: initial stage or stage of evacuation, severe dehydration or stage of collapse, and then recovery if managed timely. Initial stage. Sudden onset of watery diarrhea and vomiting with mild dehydration signs like thirst and fatigue. Severe dehydration stage. Profound fluid loss leads to sunken eyes, cold extremities, low blood pressure, tachycardia, and altered consciousness in severe cases. Recovery stage. Prompt dehydration reverses dehydration and electrolyte imbalance, with recovery occurring within 2 to 3 days if treated time. Diagnosis of cholera. Diagnosis based on clinical symptoms cannot be made. Therefore, it is necessary to undergo laboratory investigations. Among these include collection of stool sample, vomitus, water sample, blood sample, culture methods, and then biochemical tests. Stool culture. The gold standard for confirming cholera is stool culture. It involves isolating Vibrio cholera on selected media like PCBS and rapid diagnostic kits, effective for quick identification during outbreaks, especially in resource-limited settings. Microscopy. Direct observation of motile Vibrio in freshwater stool samples using a dark field microscope provides a preliminary diagnosis. Management of cholera. Immediate rehydration is critical to prevent mortality. Management involves three-pronged approach: rehydration therapy, that is the primary focus, antibiotics for severe cases, and then supportive care and monitoring. Rehydration therapy is by oral rehydration solutions, ORS. This is the first-line treatment for mild to moderate dehydration, prepared using WHO recommended ORS packets or homemade solutions. Intravenous fluids, these are required for severe dehydration. Use Ringer's lactate, Hartmann solution, or isotonic saline with potassium. Monitoring is necessary. There should be regular assessment of hydration status. How to make ORS at home? Take 1 liter of drinking water, add half teaspoon of salt, add 6 teaspoons of sugar, stir and mix until sugar dissolves. This is CDC guidelines for the preparation and use of oral rehydration solution. Antibiotic therapy, indicated for severe cases or when rehydration alone fails. This reduces the duration of diarrhea and bacterial shedding, avoids indiscriminate use to prevent resistance. If diarrhea persists even after 48 hours of treatment, resistance to antibiotics should be suspected. Supportive care. Nutritional support, early introduction of food to prevent malnutrition, zinc supplementation to reduce diarrhea severity and duration in children, electrolyte monitoring, correct imbalances, especially potassium and bicarbonate. No other medication should be given like antidiarrheals, antiemetics, antispasmodic, etc. Disease prevention. Primary prevention by health promotion and specific protection. Use safe drinking water. This provides access to treated and uncontaminated water sources to eliminate a major route of cholera transmission. Sanitation and hygiene. Promote proper waste disposal, hand washing with soap, and hygiene education to reduce the risk of fecal oral transmission. Vaccination. Implement mass vaccination campaigns using oral cholera vaccine, OCV, particularly in high-risk areas or during outbreaks to prevent disease spread and protect vulnerable populations. Oral cholera vaccines, OCV. In 1879 to 1883, major scientific breakthroughs towards the treatment of cholera developed OCV. Currently, three WHO pre-qualified OCVs are available: the oral, UV-Col Plus, UV-Col S. All require two doses to fully protect an individual. One dose of UV-Col Plus or UV-Col S provides short-term protection. UV-Col S, pre-qualified by WHO in 2024, is a simplified version of UV-Col Plus. The Shanghai vaccine is no longer produced. These are the only vaccines currently available for mass vaccination campaigns in global OCV profile, supported by Gavi, the Vaccine Alliance. Since October 2022, due to an ongoing global shortage of vaccines and with the acceptance of the Strategic Advisory Group of Experts, SAGE, only one-dose vaccine regimens are being used. OCV is safe during pregnancy. Secondary prevention by early detection and prompt treatment. Surveillance systems plays a crucial role in the rapid identification of cholera cases. Early detection through routine monitoring and reporting helps in timely interventions and outbreak control. Providing immediate rehydration therapy, oral or intravenous, to replace lost fluids and electrolytes is essential to prevent complications. Early antibiotic treatments may be administered to reduce the severity and duration of the disease, preventing further spread. These are the different means for fluid replacement. You can prepare ORS at home or by using these ORS packets. There are packaged ORS solutions, and these are obviously the intravenous rehydration therapy. Tertiary prevention by rehabilitation, ongoing care for severely dehydrated patients, including electrolyte balance restoration and monitoring for complications. Long-term measures, educating patients on hygiene and sanitation, ensuring access to safe water to prevent further cholera cases. Global burden of cholera. Cholera outbreaks occur regularly in some countries. In others, there are less frequent and it may be years between outbreaks. The number of cholera cases reported to WHO has continued to rise in recent years. In 2023, 5,35,321 cases and 4,007 deaths were reported to WHO from 45 countries. The discrepancy between these figures and the number estimated by researchers is likely due to limited surveillance systems and cases not being recorded out of the fear of repercussions for trade and tourism. WHO guidelines for cholera control include strengthening surveillance, enhanced monitoring systems to detect cholera cases early and track outbreaks effectively, repositioning OCV, stockpile oral cholera vaccines in high-risk areas for rapid deployment during outbreaks, community awareness campaigns, raise public awareness about cholera prevention, including proper sanitation, hygiene, and safe drinking water practices. Global Task Force on Cholera Control. Global Task Force on Cholera Control, GTFC, is a partnership of governmental and non-governmental organizations, UN agencies, and academic institutions with a common mission to reduce global cholera burden. GTFC partner work to develop global strategies for cholera prevention and control, support countries in long-term control or elimination of cholera through the development of national cholera plans, develop and disseminate clinical guidelines and operational manuals, support a research agenda to evaluate innovative approaches to cholera prevention and control in affected countries, and increase the visibility of cholera as an important global public health problem. Global milestones towards cholera elimination. Global roadmap to 2030. The WHO aims for cholera-free world by 2030, with a target to reduce cholera deaths by 90% through improved prevention, surveillance, and treatment strategies. Successful OCV campaigns. Mass vaccination campaigns using OCV have been successful in reducing cholera incidents in many regions, particularly during outbreaks, contributing to global progress towards elimination. Cholera in Pakistan. Frequent outbreaks. Cholera outbreaks occur regularly due to poor sanitation, inadequate water treatment, and limited access to hygiene facilities in many. Key hotspots include flood-affected and underdeveloped regions with contaminated water sources contributing to the spread of the disease. Government and NGO efforts. Government alongside NGOs conduct campaigns to improve water supply, enhance sanitation, and raise awareness about cholera prevention to mitigate outbreaks. Recent updates. A fatal case of Vibrio cholera-associated diarrhea and diphtheria in a 30-year-old carrier of beta thalassemia. While cholera is a prominent clinical threat posed by Vibrio cholera, outcomes like bacterium turning into sepsis and associated morbidity and mortality have been increasing globally in recent years. In September 2023, a 30-year-old man with a key condition of beta thalassemia presented to a tertiary care hospital with acute diarrhea, abdominal pain, nausea, and fever, and died within 36 hours of admission with acute cholecystitis, metabolic acidosis, acute kidney injury, pancytopenia, and refractory septic shock with multi-organ system dysfunction syndrome. Blood culture detected Vibrio cholera, which was further characterized by hemolysis carrying the hemolysin gene. The isolate was confirmed as Vibrio cholera non-O1 or O39 NOVC, which differed in genetic properties from the few contemporaries. NOVC isolate associated with diarrhea cases in Bangladesh. To manage the diarrhea and septicemic conditions, the patient was treated empirically with metronidazole and meropenem. However, antibiotic susceptibility testing showed the strain was susceptible to all the routinely prescribed drugs for Vibrio cholera infection. Antibacterial efficacy of bacteriophages against Vibrio cholera. This study investigates the use of bacteriophages as an alternative antibacterial approach to combat antibiotic resistance Vibrio cholera, a major public health concern. Antibiotic susceptibility was assessed using Kerr-Bio disk diffusion methods across 5 antibiotics: tetracycline, norfloxacin, ampicillin, ciprofloxacin, and erythromycin. Results showed resistance to ampicillin, tetracycline, and erythromycin, which strains remain susceptible to norfloxacin or ciprofloxacin. 5 bacteriophages against Vibrio cholera were isolated from 50 wastewater samples, and only 2, F1 and F2, showed lytic activity forming flare blast. The isolated phages were tested for host range against 6 Vibrio cholera strains with F1 lying 5 strains and F2 lysin 3, and demonstrated stability across temperatures 20 degrees Celsius to 55 degrees Celsius and pH levels 4 to 9. This study shows that these phages are highly specific, targeting only Vibrio cholera strain from various sources without affecting other bacterial species. This specificity makes them safer for therapeutic use as they are less likely to disrupt the body's natural bacterial flora. Neural network procedures for the cholera disease system with public health medication. The cholera disease system with public health mediations divide the density of human population into 7 categories based on the status of the disease, who are susceptible, educated, vaccinated, quarantined, infected, treated, and removed individuals along with the aquatic bacterial population. The motive of current research is to present the numerical performances of the cholera disease system with public health mediations by using the stochastic computing process based on the Bayesian regularization neural network. The data is constructed by using a conventional Adams scheme that reduces mean square error by distributing the data into training, validation, and testing with some reasonable percentage. 25 neurons and sigmoid fitness functions are used in the stochastic process to sort the model. The accuracy is justified by using comparison of the results, absolute error around 10 6 10 8, and some statistical operation performed. Moving forward to the MCQs. In a refugee camp, multiple cases of acute diarrheal illnesses are reported, especially among children and the elderly. The water source is suspected to be contaminated. What is the most effective immediate intervention to the control of the outbreak? A. Distribution of antibiotics to all residents. B. Providing access to clean water. C. Mass vaccination with polio vaccine. D. Isolation of infected individuals. E. Increasing dietary fiber intake.
B.
The correct answer is D. During a food safety inspection, a batch of seafood is susceptible of harboring Vibrio cholera. If the seafood is stored in ice, how long could the bacteria remain viable in these conditions before posing a risk of infection? A. 2 to 3 weeks. B. 1 to 2 weeks. C. 4 to 6 weeks. D. 8 to 10 weeks. C. Over 3 weeks. Correct answer is Charlie 4 to 6. A coastal city has experienced a rise in cholera cases following a tropical cyclone. Considering the environmental and public health impacts of such events, which of the following factors is most likely to have contributed to the outbreaks in this scenario? A. Increased food imports. B. Overcrowding in urban areas. C. Lack of access to healthcare facilities. D. Extreme weather events exacerbated by climate change. D. Decrease in vaccine rates.
C.
Yes, correct answer is Delta. During a cholera outbreak, most patients in a community develop symptoms within 2 days, while if you experience a delay of 5 days. What is the primary determinant of this variability in patient? A. Amount of bacteria ingested and immune response. B. Age of the patient. C. Season during the outbreak. D. Type of Vibrio cholera strain. E. Availability of medical treatment. The correct answer is alpha. During a cholera outbreak, a 50-year-old man complains of vomiting, watery diarrhea, and painful muscle cramps. Laboratory results indicate significant electrolyte imbalance. Which of the following is most likely cause of the muscle cramp? A. Loss of calcium. B. Excess magnesium. C. Loss of potassium and sodium. D. Low chloride levels. E. Hypernatremia.
C.
Yes, the correct answer is Charlie. During a cholera outbreak in a resource-limited clinic, there is an urgent need for a quick and efficient diagnostic tool to identify cases of Vibrio cholera. Given the constraints of resources, which of the following diagnostic methods would be the most suitable for rapid identification of the bacteria? A. Stool culture on TCBS agar. B. Dark field microscopy. C. ELISA testing. D. Molecular sequencing. Or E. Rapid diagnostic kits.
A.
The correct answer is ETA. A cholera patient with severe dehydration arrives at the emergency room. Considering the severity of dehydration and the need for immediate intervention, which of the following treatment options should be prioritized for the initial management of this patient? A. Probiotic supplements. B. Oral rehydration with homemade solution. C. Intravenous Ringer's lactate. D. Antibiotic therapy alone. E. Intravenous glucose solution.
C.
Sorry.
C.
Yes, the correct answer is
Intravenous
Charlie.
single.
A healthcare worker mentions that a cholera vaccine pre-qualified by the World Health Organization in 2024 is a simplified version of another vaccine, offering short-term protection with just 1 dose. Which vaccine is the healthcare worker referring to? A. Dukoral. B. Shancol. C. Juvicol Plus. D. Juvicol S. Or E. Global OCV stockpile vaccine. The correct answer is Delta. A healthcare worker is managing a cholera patient who has successfully received dehydration treatment. The healthcare worker recommends the early reintroduction of food to the patient. What is the primary reason for reintroducing food at an early stage in the treatment process? A. To prevent dehydration. B. To reduce diarrhea frequency. C. To eliminate bacterial growth. D. To improve absorption of antibiotics. Or E. To prevent malnutrition. The correct answer is D. A government health agency is working with the Global Task Force on Cholera Control to create a comprehensive plan for long-term cholera control in their country. Which of the following action will most likely be supported by the GTFCC in this initiative? A. Organizing a local cholera treatment facility. B. Developing national cholera plans for long-term control. C. Providing immediate financial aid for cholera patients. D. Conducting community education on the symptoms of cholera. C. Establishing a local cholera vaccine manufacturing plant.
B.
Yes, the correct answer is B. This is the key to all MCQs. This is the link to our YouTube channel where all the presentations are uploaded. Thank you for your attention.